Morning, everybody. How you doing? So let's get going. Chapter 32: Emergency care for suspected spinal injuries. Um, Sorry, let me move myself out of the way here. So, scene size up, mechanism of injury. We should, at the beginning, start to size up everything, identify what could have caused the problem, which is going to lead us to the idea of suspected spinal problem, and we're going to treat those properly. Motorcycle crashes, motor vehicle crashes, pedestrian vehicle collisions, and falls are all things would lead to this. I was just talking with EMR about this. Anything that causes trauma, blunt force trauma from the clavicles and above, automatic C-spine precaution. We expect that there's going to be some sort of cervical spine injury, and we need to treat it. Blunt force trauma, as I was just discussing, penetrating traumas to head, neck, and torso, and sporting injuries, hangings. We saw that little diagram of all those different types of spinal injury possibilities. Driving, excuse me, diving, water-related injuries, shotgun wounds to the head, neck, chest, abdomen, or pelvis because of the pressure, concussion coming through this, unresponsive trauma patients, and electrical injuries. Um, the shock involved in this can be traumatic and moving your body around. With mechanisms of injury consistent, the potential for spinal injury is there. Immediately provide inline manual stabilization. That's two hands on the head holding it still. Remember, the head needs to be in a neutral position. If it's not, we move it into. If in the process of moving the head back to neutral, eyes forward, there's pain, stop. If we can't move it, we're going to forcefully trying to move it, then stop. Use jaw thrust maneuver to open the airway because of the spinal concern. A head tilt chin lift is too manipulative of the cervical spine. But if we actually do the jaw thrust maneuver, we have less movement of the spine and we still open the airway. Primary assessment: perform manual stabilization of the spine based on mechanism of injury. Maintain manual stabilization until a thorough assessment based on your protocol does not reveal indications of immobilization or complete spinal immobilization has been accomplished. So during that assessment, we're trying to decide, do we need to fully immobilize or not? I'm going to be honest with you, err on the side of caution, treat for full immobilization because you can't see, you don't know. Mobilized patient with positive mechanism injuries who have an altered mental status, have painful, distracting injuries, and cannot effectively communicate with others. Open the airway if needed with a jaw thrust maneuver. Cervical cord injury can impair ventilation. So remember the C3, 4, and 5 keep the diaphragm alive. The principal muscle respiration with damage to those three spinal, vertebrae here, we could lose the ability to take a full breath. Skin condition can appear normal despite hypotension. High priority patients, unresponsive, responsive but unable to obey commands, abnormal respiratory patterns, and obvious signs of spinal injury. These are going to be our high priorities. During that secondary assessment, maintain inline spinal stabilization, conduct a physical exam. After assessing the neck, apply a cervical collar, assess pulses and motor and sensory function, PMS or CSM as we refer to. Secondary assessments, baseline vital signs. We're looking at gathering histories, what happened with the patient, and what do they have that we need to know about, or diabetic, seizure history, that kind of stuff, so we can be prepared for that. Tenderness along the spine as we're doing our assessments, signs and symptoms. So we're looking for that tenderness along the spine, pain associated with movement, pain independent of palpation of movement, deformities of the spine and palpation, step off. So I'm feeling along the spine. If I feel a depression or a step, the vertebrae are out of place. Soft tissue injuries, abrasions, punctures, and penetrations or lacerations to the area. We're also going to see numbness and tingling, weakness, loss of sensation or motor function, loss of bladder and bowel control, priapism, which is a spontaneous erection that happens after a spinal injury. This is a neurological issue that causes this to happen. And so when we see this in a male patient after an accident like this, we have to assume, we can see that there is actually a spinal injury, nerve damage that's causing this to happen. And impaired breathing. Whenever we have a GCS of less than 15, assessment findings that are indications of spinal immobilization, GCS, Glasgow Coma Scale, of greater than, less than 15. Suspected traumatic brain injuries, altered mental status, signs of acute stress reaction, and pain and tenderness of spinal column. Assessment findings that are indications for spinal immobilization, paralysis, weakness, numbness, tingling, or prickling sensation, hands and feet. Priapism was discussed, deformities of the vertebral column, and this is on your palpation, the step-offs or depressions. Significant MOI and any other of these findings under the influence of drugs or alcohol cannot communicate effectively, has a painful, distracting injury. Indicates inadequate breathing efforts, paralysis of the respiratory muscles can lead to respiratory failure. Respirations may be shallow with little movement to the chest or abdomen, and provide positive pressure ventilation. Those patients that have that cervical spine injury that are starting to show those irregular breathing patterns or difficulty breathing or no breathing, we're going to have to BVM or positive pressure ventilate them, breathe for them through this process. Jaw thrust maneuver, remember, most important, jaw thrust. Paralysis, uh, paraplegia, quadriplegia, hemiplasia, the different types of paralysis that we can actually see here, where we have two, the arms can't move, the legs can't move. Maybe it's right or left side that's having issues. So it could be any number of these different possibilities, but we need to assess for these so we can identify the nature or, what's actually going on because of the spinal injury. Inadequate circulation. Vasodilation leads to hypotension and poor tissue perfusion. And during a spinal injury, we have concerns of shock because we no longer control those blood vessels. The skin may be warm and dry, and the heart rate is normal to slightly decreased. Always look at other reasons for hypotension. So we need to start looking at other cardiac issues and medication issues that could also be leading to this hypotension. Shock being one of those big ones, but again, spinal injuries could lead us to that possibility. Use standard precautions when we're taking care of these patients. Establish an inline spinal stabilization. That's 2 hands on the head as we begin our assessment. Hold that person still the best we can. Maintain that airway and breathing. Use a jaw thrust maneuver if necessary. In most cases with traumatic injury, MOI that shows possible spinal injury, jaw thrust should be what we use. Positive pressure ventilation for inadequate breathing. Maintain an SpO2 greater than or equal to 94%. Magic number, guys. When we hit 94% or above, we're good. Leave them be. It's when we fall below that 94%, we need to start providing O2. Assess the pulse, motor function, and sensation in all extremities. Assess the neck before applying cervical collar, and then apply the collar properly. Measurements, as we talked about, from the jawbone to the trapezius muscle, using your fingers on the collar, adjust that collar to fit properly. Mobilize the patient on a longboard. After mobilization, reassess pulse, motor, and sensory function. This is the PMS or CSM. And then we're going to start talking about transport. Reassess airway, breathing, vital signs, complaints, and interventions. Always watching your ABCs because those can change at any point in time. Vital signs are a window to the inside, so we have an idea of what's actually happening with the patient. Talk to them about their complaints. Has it changed? Is what they initially were complaining about, is it still the same? Is it worse? Is it better? And then we should have placed some interventions, oxygen on the backboard, those types of things. Assess those interventions. Are they still doing their job? Are they still in place properly? Do we need to adjust them at all? One of the big adjustments that may need to happen on a C-spine patient, just so you know, we got them on a backboard, below their back, at the small of their back, the lumbar area, we have a curve, right? And you're on that flat board. Now, most of us can probably lay on that board for a short period of time with no problem, but some of us right off the bat are going to have a lot of pain in that lumbar area just because we have no support there. So it wouldn't be a bad idea in those cases to roll up a small towel, slide in between the board and the back to give a little bit of lumbar support just to kind of take away the pressure. Understood. If they're having an airway issue, breathing issue, their life threats are high. Okay, we've got some serious concerns here. I ain't worried about the lumbar support. I want to take care of life threats first. But if we've got a patient that's viable and has a possible spinal injury, is talking to you, vital signs are fine, but they're complaining of now new pain. That complaint is now changed, and the lumbar support really, my lumbar area is really hurting. Pat it, give them a little extra support. We're there to care for that, right? All right. So there should be 3 lectures out of this chapter. I took care of this one right now, and I will be working on the next one. I'm going to post a video about GCSs just so you guys have an idea of what that actually is, because we discussed it a bit here. I want to make sure you guys have that information. Okay. I'll post this up today. Please take a look at that, and please make sure you look at your case studies that are also up. Make sure you read through those and answer those questions. Okay. Thank you very much. Bye.